Well, thanks so much for coming. My name is Jennifer Young. I am a UNC CHIP student, and for my MPS internship, I interned at the Duke Institute for Health Innovation. And today I'm going to be talking about uh, the primary project that I worked on, which involves identifying cardiac decompensation and using evidence-based diagnostics to assist clinicians in real time. So just a quick outline or agenda for the presentation. First, I'm going to be going over the team description that I worked on. Then I'm going to get into the project's description and its details. Then going into kind of the current workflow and talking about the future work plan for the project. So the Duke Institute for Health Innovation is a team of data scientists, data engineers, and clinicians. The mission of the Duke Institute for Health Innovation, or DIHI, is to catalyze transformative innovations in health and healthcare. One project the team is currently engaged in working on aims to help clinicians identify patients with cardiac decompensation earlier so that appropriate interventions can be used to improve patient outcomes. This project is a collaborative effort from the team at DIHI, Duke's cardiology team, and Duke's patient response teams. So what is cardiac decompensation? Well, put simply, cardiac decompensation is an abnormal condition of the heart where it is no longer able to maintain efficient circulation. Cardiac decompensation is a broad descriptor for a complex set of symptoms. Patients with cardiac decompensation are at risk of developing cardiogenic shock, a disease process which is associated with a 30% in-hospital mortality rate and a 50% mortality rate after 1 year of diagnosis. Detecting cardiac decompensation and diagnosing early-stage cardiogenic shock is complex as it relies on rapid integration of vital signs, physical exam findings, lab data, imaging, and invasive hemodynamic data. Clinicians must synthesize real-time physical findings and biochemical markers for these patients in addition to managing their entire caseload. This often leads to a delay in recognition, a delay in early interventions, unanticipated ICU transfers, and overall worse patient outcomes. So how do we identify cardiac decompensation? Well, the Duke cardiology team used a combination of their own clinical expertise with evidence-based practices to develop a set of 6 phenotypes or attributes to look at in patients within the Duke University Hospital. Briefly, each phenotype can be described as follows. Hypotension is 2 low blood pressure readings from a patient within a 6-hour time frame. End organ dysfunction specifically looks at a patient's lab results, including an increase in their serum creatinine, lactate level, AST and ALT levels, and their total bilirubin levels. Hypoperfusion is an interesting one because it's a combination of the hypotension phenotype and the end organ dysfunction phenotype within a 24-hour period. Vasoactive medication looks at a new or increased dose of a vasoactive med being given to a patient, for example, dopamine or epinephrine. Respiratory decline is about looks at an increase in supplemental oxygen, or if a patient's oxygen saturation drops below 91%, or if they have an arterial blood gas reading that comes back and it's not looking so good. Respiratory intervention is defined as an escalation in respiratory support, specifically things like a high flow nasal cannula, a non-rebreather mask, a BiPAP machine, or in worst cases, intubation. So incorporating the evidence-based part, they also wanted to incorporate the Sky stages of cardiogenic shock. So the phenotypes identified align with those classification guidelines. Skyshock stage classification is a set of guidelines developed by cardiologists and endorsed by organizations like the American Heart Association, the European Society of Cardiology, and many others. These guidelines include criteria for evaluating patients for cardiogenic shock, including biochemical markers such as lab results and hemodynamic markers like vital signs. Because our goal is to detect and intervene early with patients, our phenotypes closely align with Skyshock stages A through C. So you can see in the pyramid that is patients that are at risk, beginning cardiogenic shock, and in classic stages of cardiogenic shock. So what does that all mean? Well, using these phenotypes, the team at DIHI developed a tool for clinicians to monitor patients in real time. The Cardiac Decomp dashboard began its pilot program in June 2021. Using a retrospective analysis, DIHI determined that the units with the highest risk were the cardiology units, specifically cardiac step-down, general cardiology, cardiothoracic step-down, and the cardiac ICU. This dashboard was made available to the patient response teams as well as the floor staff on those units, which were identified as having the highest risk for patients with cardiac decompensation. So if I'm a floor nurse or if I'm on the rapid response team as a nurse, I can pull up this dashboard and obviously I've blanked out the patient information, but I've added in a sample patient known as, seen here as a patient. So if I pull up this dashboard, it shows me the patient's name, their MRN, the bed number that they're in. It also shows the number of phenotypes that they've met in the last 12 hours. And if I look here, a patient has met 3 different phenotypes. And if I was in the dashboard and was to hover over these timestamps, it would show me where it's pulling that information from. And this is a Tableau dashboard. So one thing that I was particularly interested in was analyzing the output of the dashboard for its 1-year anniversary. So it's been up since the end of June 2021. On the left, you'll see the distribution of each phenotype in the cardiology units over the previous year. There were 2,376 unique patient encounters where a patient met at least one phenotype. In that time frame, there were 749 rapid response team encounters. 504 of those were consults, which are proactive visits, where an RRT member consults with the patient's nurse for a variety of reasons, including when a patient begins to deteriorate or if the nurse is just having difficulty with a lab draw. 249 of those encounters were RRT events. These are a more emergent concern, where an RRT nurse is called to assist with a patient intervention. Events are generally reactive and involve a greater degree of intervention, like transfer to the ICU. It's the difference between calling the RRT team and asking if they can come take a look at a patient versus calling them and saying, we need you to come right away. So on the left is a line graph showing the number of RRT events. Again, those are the reactive events, the more acute events. So the number of RRT events by month in the cardiology department. There's a large spike around the December to February time period, which could possibly correlate to the increase in hospitalizations during the holiday season or the spike in COVID cases around that time. Interestingly, 63% of patients who had an RRT event met a phenotype prior to that event. Some patients met more than one phenotype, and on the bottom right, you can see the phenotype that occurred most frequently prior to an RRT event was hypotension. So while early adoption of the dashboard seemed promising, the tool's become underutilized for a variety of reasons. For example, clinicians having to use a separate system, so they have to log into the separate Tableau system. Hosting problems, specifically long load times, lack of real-time notification, and poor user-centered design. So the collaborative team, and that's DIHI, Duke Cardiology, and the patient response teams, were awarded a grant by the Gordon and Betty Moore Foundation to use this previous work to develop a clinical quality measure. The current work plan involves using feedback and results of the pilot to improve the dashboard. It also involves interviewing stakeholders and convening a technical expert panel, also known as a TEP. So this slide shows an overview of the measure development process as outlined by the Centers for Medicare and Medicaid Services. Development of a new quality measure is an exhaustive task that generally takes well over a year. Our team is currently somewhere between steps 2 and 3, so measure specification and measure testing. Our focus right now is on convening the technical expert panel meetings, collecting qualitative and quantitative data, and iterating on the measure as necessary. The future work plan involves collaboration with partners to develop a structural quality measure for patients with cardiac decompensation and early stages of cardiogenic shock. It also involves implementation of that quality measure within Duke University Hospital and reaching out to organizations for validation and endorsement, such as the American Heart Association. Finally, will apply for quality measure recognition through the Centers for Medicare and Medicaid Services, or CMS. And that's my presentation. So thanks so much for your time, and I'm happy to take any questions.